Good morning, everyone, and welcome. Welcome to the National Council on Interpreting in Healthcare On the Road webinar, Building Language Access Infrastructure in Healthcare. The NCIHC is a multidisciplinary organization whose mission is to promote and enhance language access in healthcare in the United States. In line with its goal of collecting, disseminating, and acting as a clearinghouse on programs and policies to improve language access in healthcare for limited English proficient and deaf individuals, NCIHC sponsors a national dialogue of diverse voices and interests. Over the coming year, 2022-2023, NCIHC will hold a series of regional language access learning events under the umbrella NCIHC On the Road. And this live webinar is the kickoff to this year of On the Road activity. In this webinar, we'll be exploring legal and regulatory requirements around language access in healthcare, as well as implications for patient safety and patient experience. And we have three distinguished subject matter experts on our panel today. We want to welcome Bruce Adelson, Esquire, CEO of Federal Compliance Consulting, LLC. Bruce is an adjunct professor of law at the University of Pittsburgh School of Law and an instructor of family medicine at Georgetown University School of Medicine. Welcome, Bruce.
Thank you very much. It's a pleasure to be here.
We also have Dr. Cristina Cordero, PhD, Project Director of the Division of Healthcare Quality Evaluation at the Joint Commission. Welcome, Dr. Cordero.
Hello, everyone.
And we have a third panelist. We're very excited to have Dr. Deirdre Mylod, PhD, Executive Director, Institute for Innovation, and SVP of Research and Analytics at Press Ganey.
Hi there, so glad to be with you today.
So thank you to the three of you for joining this exciting conversation that we hope to learn from your insights and guidance around what programs and services need to be in place for healthcare organizations, large and small, to provide meaningful access to linguistically diverse populations. We also have an ASL interpreter present for our event. You can see Amy on screen. We want to thank Amy for assisting us in getting this message out in ASL as well as in English. This webinar has had an unprecedented number of folks registered. 650 have registered to attend today, and we hope that many will join the live webinar. A recorded version will be made available free of charge to the public and to healthcare organizations on the NCIHC website. So we invite you to check us out at www.ncihc.org. So let's get the conversation started. We have three amazing panelists. We have 8 really meaty questions, and we have potentially 600 attendees. In 1 hour, we may not make it to all of the attendee questions, but we encourage folks to put their questions and comments in the chat. We will share those with the panelists after the session, and we may gather from those questions and comments input and content for future webinars and learning events. So let's get started with the first question. A 2016 survey by the American Hospital Association of more than 4,400 hospitals indicated that 44% did not have a language access program at the time of the survey. It's a pretty high percent. We know that hospitals that didn't build language access infrastructure before the pandemic may have struggled to build capacity during the pandemic. So as we emerge from the pandemic into a bright new future, what people, what technologies, and what policies should healthcare organizations have in place to ensure meaningful access for patients who receive care in languages other than English? This is an open question.
Well, let me jump in quickly, and I am very mindful of the time. It's a great start-off question, and I think that the mention of the pandemic is particularly salient because we learned a lot of hard, tragic lessons over the last couple of years with healthcare providers, first responders not providing federally compliant, effective language assistance, death, injury, disability, just because people weren't prepared. And so my advice with the first question is be prepared. Plans, policies, education, understanding that, and myriad other things that we could talk about. But let's take lessons from the pandemic and commit ourselves not to let the language access crises of the last couple of years happen again.
Absolutely.
I'll
Tina.
just jump in and say, we still do have many of our standards in place, our accreditation standards for our organizations that still require organizations to provide interpreting and translation services. We've had requirements in place for years about the qualifications of the individuals that provide those services on behalf of a hospital, for example, or another healthcare organization. We've still had, again, longstanding requirements around collecting patients' preferred language and race ethnicity data. And so even though, as you mentioned during the pandemic, we also shifted some of our survey activities to virtual surveys. And there was a point where we were offline for a little bit and kind of doing some other work with our organizations as we shifted our survey model to be less of an on-site process and more of a virtual process. But we still were able to look into some of these issues and still survey through our patient tracer methodology and still look into the way organizations were addressing these issues.
Yes.
And I'll just follow on that, when we think about, we define patient experience at Press Ganey as the sum of the safety, the quality, as well as the perception of care. And so that's a pretty big umbrella that is touched in every way by access to appropriate language services. We also know that post-pandemic, we're still in the midst of the pandemic, staff are incredibly burned out and worn down. And we know that staff want to be at a place that provides high quality. They want to be in a place that provides safe care. And we know that safety has been challenged during the course of the pandemic. So the idea of not having a service that is both legally required and also promotes safety and quality for all people, that just, it harms the patients, but it also harms the staff who want to be part of the highest quality organization. That's why they're in healthcare, and it's often what keeps people even from the brink of burnout. So it's critical for everybody involved.
That's a great insight. So I'm hearing that patient experience and staff experience are connected, that patient safety leads to perhaps lower burnout, higher staff retention. Staff can feel proud of the organizations and the systems that they work in. Now, Tina, you mentioned policies and guidelines. Bruce, you mentioned a legal framework. That brings me to my second question. What is the legal framework for language access in healthcare settings? What laws, what regulations should healthcare organizations keep in mind as they develop or strengthen a language access plan?
Wait, in 2 minutes. Okay, so let's go. So I'm, as you said, that there are some clear federal legal requirements under Title VI of the Civil Rights Act of 1964, Section 1557 of the Affordable Care Act. There are similar requirements for communication with people who have communication disabilities. So in Braille, for example, or in American Sign Language, there are 20 plus years of guidance, regulations, including some guidance documents that I wrote during my career with the Justice Department. But I think what's more than that, in two ways, what often does not get discussed is the linkage between failure to provide a language assistance at all or effective language assistance and liability for negligence, medical malpractice, deviation from the standard of care, and multiple other potential causes of action. That's rarely discussed, frankly, because it's complicated. And the federal agencies do not provide information about this. But from my experience in the courtroom, my experience in the work that I do now, and with DOJ, there is no question there is an ineluctable connection between language assistance and liability for negligence and medical malpractice. And one final point. You mentioned at the beginning that I teach at Georgetown Medical School, which is true. One of the things that I have found in my career is the paucity of education and information starting for first-year medical students about the benefits, requirements, liability issues, patient care, patient satisfaction involving language access. So I would posit that there should be a new urgency to focus there on early education, resident education, and then early career education of physicians, because that's where it's all starts. My students regularly tell me we've never heard of anything like what you're telling us. So hopefully I kept to the 2 minutes, and I'll stand back for a moment now. Thank you.
That was great. I've never heard such a succinct summary of the law, the legal foundation for healthcare language access. Tina, Deirdre, do you have thoughts on the framework for language access in healthcare, and perhaps from a regulatory perspective? What should health systems consider as they begin to draft a language access plan or build up their program?
Sure, I can jump in here. I talked a little bit about some of the standards that we have in place already, but I think when you think about how to build a program, many of our requirements around how you provide interpreters and provide translation services are very flexible. So we do allow organizations to figure out what services will work for them and meet their patients' needs, what reflects their patient population. And so they have, opportunities to figure out what mixture of services they want to use, if they're using in-person interpreters or they have contract vendors and things like that. So it's sort of we give flexibility to organizations to create a program, but we want to make sure that the services that are provided by qualified individuals, and that patient provider communication is effective. So while we don't have very specific things about specific limitations or things about how that program is constructed, we do want to make sure that whatever communication is occurring between patients and providers as they're doing assessments or doing discharge planning, or just exchanging information in general, that patients have that opportunity to have a meaningful two-way exchange of information between patients and providers. And so again, that flexibility is in place, which is helpful for organizations as they design a system, but we do still want to make sure when our surveyors are on site in your organizations that that is an effective system and that the patients are being communicated with in a manner that meets their needs.
And then from a framework perspective or a strategic perspective, the last 2 years, there's been so much additional work on equity across the healthcare industry. And my colleague, Dr. Tejal Gandhi, had a paper where she talked about that there's no such thing as safe, high quality care that is inequitable. And I think that statement helps us frame the idea that language services, like other equity work, can't be a silo. It's not in addition. So I guess what I'm trying to say is that the framework is that it has to be integrated with your broader strategy, that it is a component of providing safe, high quality care. And if you're not providing inequitable care, you're not achieving the goals that you're setting out for yourself. So it really needs to be part of the strategic framework overall.
And if I could just quickly add something to that point, which I think is great, but I would rhetorically ask everyone, hospitals routinely have systems in place for washing your hands, for disinfectant, for a clean environment. And that is seen as being absolutely essential for healthcare. Language access needs to be the same. Not everybody sees it that way, but I view that as a lack of education and understanding. But if you have a hand washing regimen in your hospital, you also need a regimen requirements program for language access, which must be effective and legally compliant. So you wash your hands, learn how to use interpreters, translators, and actually have a language access plan that is effective and compliant.
Absolutely. These are some really great takeaways.
A lot of amens from the audience on that one.
I was going to jump in
absolutely.
here. Just to tack on to what Bruce just said, I was going to save this comment for the end of the webinar, but since we brought it up already, I think one of the things that may help kind of elevate not just language access, but much of the work that many of us are doing around disparities and looking at health equity. We just released our pre-publication standards at the Joint Commission yesterday, so sort of hot off the internet for those of you who haven't seen the pre-publication requirements. But there's a new set of standards in our leadership chapter that really talk about looking at reducing healthcare disparities and making that a quality and safety priority. So much in the way that Bruce just said, we're really looking at taking these types of issues and saying, just like the work that you're doing around hand washing, antibiotic stewardship, fall risk, the amount of attention and detail and awareness and sort of enterprise-wide type activities that you're doing for many of those issues, we're hoping that organizations will turn that same type of awareness and energy into looking at disparities and some of the new requirements that we have about just making this a quality and safety priority. And language access plans and language access in general will be a large part of that.
I know that many in our audience are hospital administrators and healthcare administrators, not just of language access programs, but also of compliance and risk management and patient experience. So if I'm an administrator, I'm listening to you and I'm hearing that, okay, I need to draft a language access plan. I need to begin to build a language access program, but I also need to build an education program to help the providers of today and the providers of tomorrow understand the why and the connection between, you know, communicating effectively in the patient's non-English language and patient safety and risk management and liability and patient experience. And really, there is no health equity without language access and building a culture of language justice within an organization. These are some fantastic takeaways and quite a lot to think about for administrators of hospital and healthcare programs. So these are concerning times. Interpreters have been commenting with each other that throughout the country, we're seeing some hospitals downsize their interpreter staff or even eliminate on-site interpreter services entirely. And at the same time, other health systems, sometimes in the same city or the same neighborhood, are expanding their language access programs. So we're seeing shrinkage and expansion at the same time. So, in your professional opinions, what is the value added by the staff interpreter that belongs to the hospital as an employee? And is there any risk in outsourcing all of a hospital's language access?
Vanessa, you just said one of my magic words, which is risk. I live and work in risk, talk risk every day. And I think to your point that when there are a lot of organizations that I've worked with, that I've legally assessed, that I've written plans for them, that they outsource their language services to entities that are not fulfilling their needs as an organization. In fact, I had worked with a large healthcare provider out west once who was being poorly served by their language access provider. So what I advised them and what they eventually did is that they sued the language access provider for breach of contract because the provider was not providing the services that the contract stipulated. They got themselves out of the healthcare system, got themselves out of a difficult situation, and then understood that, wait a minute, we're the contracting party. We have some say here in how the services are actually being provided, because you know what? There are a lot of people who don't understand what the legal requirements are, even though we're talking about laws that go back more than 2 decades. So I think that that's a big part of it, having an aversion to risk and understanding that the language services company that comes in with the cheapest bid, who can't really explain how they provide language services, is probably not the best option for you. So vet the people that you work with, understanding that you, as the healthcare system, are the one that is eventually legally responsible and liable if there are failures of language access.
There's some great takeaways.
And related to some of the equity work, I'm not saying that this couldn't occur effectively with outsourced services, but we've seen a number of organizations that the language and interpreting services are a really integral part of the equity work and the equity teams and the quality teams. For example, one necessity for doing equity work is to have accurate information about patient identity and to ask patients, for the patients to serve as the source of truth for that. And so not only are interpreters the ones who can get information about patient identity, how they identify racially, ethnically, or SOGI data, but what several organizations that we work with have done is to give the interpreter staff the ability to edit the EHR, to input information to the EHR, because they are getting better, more accurate information from those patients than those who are just English speaking and asking something or handing somebody a form. So it really points to that notion of staff interpreter services being integral into other systems of safety, quality, and equity that may not work out in the same way in an outsourced scenario.
Yeah, there's absolutely value in belonging and having interpreters that belong to an organization and can participate in these interdisciplinary health equity initiatives. Having worked as a hospital-based interpreter and a language access coordinator in a hospital setting, I know that staff interpreters are often the first ones to point out the risky communication practices and to say to providers, that's risky and we don't do that here. And this is a better practice and this is what we do here. And really promote that culture of language justice. You can't outsource language justice. Excellent. So this is a question for everyone, but I'm going to invite Tina to speak to it first. You know, bilingual, bicultural clinicians are often considered the gold standard in the care of patients with limited English proficiency. But that's really only true if the provider is actually proficient in the patient's language of care. Now, the Affordable Care Act, Section 1557, establishes that organizations need to ensure that bilingual clinicians and support staff can effectively, accurately, and impartially communicate directly with individuals with limited English proficiency. And I know that the Joint Commission also speaks to this, the need for hospitals to ensure that bilingual providers can communicate effectively and in a way that meets patient needs. So how does having a formal vetting process in place reduce risk to patients, to providers, and to organizations?
Sure. Well, I mentioned a little bit about some of our existing standards, but we do have standards in our provision of care chapter as well as in our patient rights chapter. Again, focus on this issue of making sure that patients and providers are communicating effectively. So in general, but when it comes to this particular example with bilingual providers, I mean, we still want to make sure that organizations have a process in place to make sure that that communication is effective, and so that patients receive information, if they're receiving information in a different language directly from the provider, that they get information that they understand and then they can act upon. They understand when they sign informed consent documents or again discharge instructions and things like that, that they understand that information and have that opportunity to ask questions and have a meaningful conversation about their healthcare. And so we have, I mentioned some one element of performance in place, one requirement in place around qualifications for interpreters. So if a bilingual provider is serving as an interpreter, then some of those requirements would apply in that case. But then we also have other requirements just about that patient-provider communication. So I think that would cover much of what we're talking about here. And I think we have a frequently asked questions document up on our website that talks a little bit about this and some of the nuances of just, again, making sure that communication and interaction is effective. So if we have a surveyor, for example, come out onto a site and they pull a patient tracer patient, for example, for those of you who are familiar with our process, and they see that that patient speaks is limited English proficient, or they identify the patient's preferred language, then they can start to talk to the staff that may have interacted with that patient, talk to language services, ask some of the questions about what your language service program is about and how you identify interpreters and what their qualifications are. And if you're using different staff members across the organization to interact with patients, again, directly in another language or to serve as interpreters, they can start to ask questions around that process and just to make sure that organizations are providing communication in a manner that is meeting the patient's needs.
I'm peeking
Also,
over at the, oh, go ahead.
I just wanted to add to what Christina was saying about the language abilities of presumptively bilingual providers. It is legally required that all federally subsidized healthcare systems, hospitals, providers, solo practitioners assess the language ability of staff, and in this case, bilingual providers. I recently did I think it was like a 60+ page language access plan for an organization that did not know about all these assessment requirements. And boy, do they know, not only do they know now, but they were really surprised to hear that, oh, well, Bruce, just because you say you're fluent in French, we can't just go with that. We actually have to do an assessment. And the law requires that you must be fluent in specific terminology that relates to your work in a federally subsidized healthcare facility. So there are a lot of nuance to this, in addition to what Christina said about the Joint Commission. There are specific legal requirements, guidance documents going back years that talk about this, and there is no question that this is a legal requirement of places that take federal funding.
Absolutely. I was peeking over at the chat while Tina was talking, and I see a comment that asks, who decides if communication is effective? And this reminded me of a comment that was written in Portuguese on a patient survey in an organization that I worked with. And the patient wrote, "I love my doctor. He thinks he speaks Portuguese. I sometimes understand him." And to me, that's a mixed bag. I love my doctor. That's great. He thinks he speaks Portuguese. That's a red flag. And I sometimes understand him is really a risk issue. And this is interesting because many, self-professed bilingual providers will say, well, I understand my patients just fine. But then there's the flip side of it. Do your patients understand you? And do they have the agency to say, I do, or I don't, or this is effective for me, or it isn't? So there's a lot to unpack there, but a formal vetting process is absolutely essential. So that brings us to our next question. The best programs are co-designed with patients and with the community. Deirdre, what are some promising practices for engaging patients across languages? And what are some things that hospitals can do with tools like Press Ganey to assess not just the care experience, but also the language access experience?
Sure. What you're really getting at here, I think, requires two things. So in order to co-design with patients and communities, we have to be able to accurately identify the communities. And then we have to be able to get feedback from these communities, be willing to listen and have effective ways for listening. So I'm going to check off a whole quick series. I think the first thing is just being strategic about your use of administrative data. What do you know about the patient, their experiences, or the processes that they went through? So that's where really leveraging what's in the EHR, capturing the right information. So the first part of that, most important part, is having good, solid practices to gather information about language needs as well as other identity information. Having staff be well trained to ask patients what their preferences are, to have multilingual opportunities for patients to provide information about their preferences, and to have tidy and accurate ways to store that in the EHR so that you can leverage that information, right? So it can be very, very easy to know who has already told us the languages that they prefer to have medical conversations in. From there, the traditional modes of getting feedback is our patient experience surveys. And I want to be very frank that English speakers and English language surveys tend to have higher response rates, right? So out of the gate, we know that there is inequity in terms of the standard processes, whether it's Press Ganey processes or the CAPS processes that the government requires, standard tools. We might have less response from multiple languages, even when we provide the surveys in the appropriate languages. We provide surveys in over 30 languages. So you should always provide the right language, but we need to enhance the process beyond that, right? So on standard traditional tools, organizations can ask custom questions. They often ask about like availability or timeliness or the helpfulness of language services. Now, sometimes in the past, organizations might not be able to provide information like who used interpreter or language services. And so they didn't want to put that question on every survey. But now that most organizations use text-based surveys, text-based or email electronic surveys, you can have branching options. You could ask a patient in the language, if you have the language code for the right language, you could ask the patient, did they use interpreter services, and then ask subsequent questions about that. Or you can, we now can look at things that are in the EHR and the codes coming across, and based on that, if you have a flag for this patient received support through language services, certain additional questions could be asked. The other component, though, is asking patients during care, and you do for feedback. We do have to be careful. There are rules about what can be asked and in what format, so that it doesn't bias regulatory surveys that occur later. But we can ask patients about the safety and quality of their care, just like you can ask patients about their comfort levels or if they have any additional questions. So using things like QR codes or rounding tools that are in the appropriate language so that patients could give feedback. We recommend that partly because of the rules about post-care surveying, but partly the patient is most worried about their own health experience. We should only be asking them things if we're going to fix it for them. But that's occurring more and more. And then finally, the thing I do want to touch on is using that administrative data really effectively to understand equity. And this gets back to some of the earlier discussions of messaging or creating the business case for language services. All outcomes should be segmented by race, ethnicity, and language variables. One system that we worked with when they looked at ER wait times, the full time that patients were in the ER, they found that those who were not English speakers were spending hours longer in the emergency department. And they tied it back to a well-intentioned physician who in the midst of triage would take an English speaker first, assuming it will take a while to get language services here. So I'll take care of this other patient, not realizing that they were creating systemic discrimination against people that were not speaking, orally English in the moment. And so not just outcomes like process and throughput outcomes, but segmenting all patient experience outcomes by language needs, language preferences, and then combining that with race and ethnicity so that we can really target not just what did you think of language services, but did you get the information that you needed? Were you involved in decisions about your care? Were things explained to you? Were people compassionate towards you? Those all can be segmented by language variables. And that's how we get to really understanding the needs of all of these patient groups. I think I went over 2 minutes, but sorry.
No, that was great. Though one of the conversations that we always had in my hospital system was how it really is important to look at race with ethnicity, with language, because if you look only at race or race with a few pre-selected ethnicity boxes, you're going to miss entire segments of your population. There are consumers of interpreter services, patients who receive care in languages other than English, who may identify as white non-Latino. So if you're not looking at language of care, you might miss large groups of Brazilian or Middle Eastern or North African patients or others. So super, super important to look at all of those when you're looking at health equity and patient experience. Race, ethnicity, and language together are important for the stratification of data. And I love your comment about why do we ask? We ask not just because we're required to, not just for the purpose of knowledge, but for the purpose of co-design. We're asking so that we can fix something and make it better in the way that patients tell us it needs to be fixed. And that's really, really interesting. Tina, Bruce, do you have thoughts on patient engagement, ways to connect with different communities?
One of the things we encourage organizations to do as well is to incorporate patient and family advisory committees into their organizations. And so you get that opportunity to work with the community and work with patients and hear what their needs are. And there can be, areas of disparity that come up in those conversations. They can help design, as we for this question, help design your language access program, but also take a look at some of the documents that you have and look at, other larger issues of just readability in general or things like that, where you can get feedback from patients and families just to make sure, again, that this theme of just the way that organizations communicate with their patients is effective, whether that's through documents, through the conversations that they're having about healthcare, or through other processes throughout the organization, and to help them navigate through how they make appointments and things like that, just to make sure that you get that perspective, in a proactive way as well. Just to make sure that you're designing systems and processes that make sense for your patient population and truly do meet the needs that they have.
And I all these are great points. I would add that the requirement, the importance of communication really is seen as what we've been discussing here about surveys and getting information from your patients and designing systems that will actually provide the communication that works best for the patients and for patient care. I also want to mention very quickly that I look at this as an opportunity to talk a little bit about liability. That liability in the courtroom is determined by a combination of everything that we're talking about. So if you have A, B, and C, but you don't have D, E, and F, that can help me if I'm suing on behalf of a patient to prove what I have to prove. If I'm defending a healthcare provider and we don't have D, E, and F, then my thought might be, we're going to have to scramble to figure out how to address that. So all of this is linked. You can't just take one, like, on a menu, well, I'll have this and that, but I don't want that. You have to do all of it. Because if you don't, you give somebody like me the opportunity to have a fun experience with you in front of the jury or in front of my old friends at the Department of Justice.
I love that. It's not a menu, it's a comprehensive approach. And speaking again about surveys and a comprehensive approach, there are folks that respond to paper surveys. There are folks that only respond to electronic surveys. There are folks that don't respond to any kind of contact except telephone. And there are folks that don't answer their phones. And so if you really want to know the patient experience, you have to use all of those different modalities of connecting with patients, because each one will reach a different segment of your patient population. And it's expensive. It's expensive to do surveying over the phone. It's expensive to do it in multiple modalities. It's expensive to send someone door to door or into a community center or into your exam room. But doing all of these things together is really the only way to know the experience for all of your patients. Very, very interesting. So thinking of hospitals that don't have a lot in place, if a hospital doesn't have a robust language access program, where should it focus its improvement work? What are some resources or first steps that you recommend?
The first and easiest one is CAP surveys all ask about language spoken at home. So even if you don't have interpreter services and you don't have people that are observing opportunities, as you pointed out earlier, like this is not going as well as it should, everyone has access to CAP surveys with an HCAP survey, or other CAP schools can segment their data by the what that respondent said their preferred languages at home was, and see what those gaps are. Most CAP surveys also allow, they don't necessarily have verbatim comments, but most allow for including verbatim comments that can be translated. And so that can give you some insight. And then there's also some, in addition to all of the multimodalities that you just mentioned, patient and family advisory councils, PFACs, can be very, very important. The University of Rochester has a longstanding PFAC for the deaf community that has really transformed their understanding of what they need to do to serve that community within their healthcare organization. So I think there's a lot of ways that people can get started, even in advance of getting greater improvement, language services in place.
And I would add to that
resources.
And I think that's a great, those are really great suggestions about understanding the universe of what you're dealing with. My thought about the next priority is training, not 5-minute training or 10-minute training. Effective, really knock you out training, where there is an interactive discussion of real cases, not made up cases, not the intoxicado case from the 1980s, cases that are happening right now that resulted in death, permanent disability of a baby because of the failure to provide effective language assistance, and what the cost was, the monetary cost to the healthcare system in that particular case. Good, effective, interactive, rock your bones training that really explains all of this to people so they understand that this isn't something that you do on the weekend or as an afterthought. You wash your hands in the hospital, you do this in the hospital too.
That's fantastic. And I think there is a perception among interpreters, among hospital language access administrators, among others in hospitals that, well, we probably won't get sued. I've heard comments like, well, only deaf patients sue. Undocumented patients never sue. The likelihood of getting sued is very slim. Can you speak to that
And
make it a little more current and real for us?
I've had hospital administrators tell me exactly the same thing. When we sit down in the conference room and close the door and they talk about what they perceive as their liability risk with someone who's deaf and someone who's limited English proficient. But one of the things that, again, it gets no public attention because people don't really understand or are aware of it. There are regulatory approaches to language assistance, whether it's in healthcare or in the Department of Transportation, that have resulted in hundreds of millions of dollars being withheld from federally subsidized organizations because of violations of Title VI, for example, and failure to provide effective language assistance. Now, can you Google this? No, because it's not public. But I've been involved with organizations to help them get their funding back. And what did we have to do? Well, all the things that we're talking about: training, data, language access planning. Sometimes it took several years for them to get their money back. But this is kind of a unknown aspect of compliance that you're right. I mean, you could be sued at any time. There's no way to calculate the odds of being sued on any given day. However, I know I've been involved in lawsuits, either confidentially or otherwise, that involved failure to provide effective language assistance, and, as I said, involved in situations involving hundreds of millions of dollars that were taken away from places that receive federal funding or withheld, or organizations were told you're not getting any federal funding for 2 or 3 years because of violations. So stuff goes on behind the scenes that people might not be aware of. I'm not suggesting that that's a panacea or takes care of all the issues, but I also think that since one of the topics is about advocacy and knowledge, direct advocacy is very, very important. And I don't want to get off topic completely, but making sure that the people who regulate the laws in the federal agencies understand where you're coming from and understand what your priorities are.
That's great. So it's not just about splashy lawsuits in the newspaper, it's also about loss of funding, which may be a bigger issue in some organizations.
Yeah.
And advocacy with policymakers and lawmakers is very important.
Mhm.
Excellent, excellent. So we know that expanding language capacity in an organization is the right thing to do. We've established that it's legally required, but is there also a business case? And Deirdre, I heard you say something about business case. Is there a correlation between building language access infrastructure and market share?
So the researcher in me would say, I don't have hard data to take the language access attributes and connect it to market share, but I think we have some really good circumstantial evidence that we should just review quickly. So we know that market share is absolutely related to patients' intention to recommend an organization. When a patient would recommend, they're saying that the care was of a level that they trusted, that they would intend to come back, and that they would tell their friends and family that they should go there. And so most organizations that are focused on patient experience think a lot about how to optimize likelihood to recommend. And they do that in 2 ways. The first is they look at what are the key drivers, what are the highly reliable behaviors or experiences that have to happen for every patient in order for patients to want to recommend an organization. And even if the measures are a little bit different for different, if it's emergency department or the practice setting or the hospital, it almost always comes down to patients feeling the teamwork among the teams, feeling respected during care, and getting the information that they need. And if you have language barriers that are not being addressed, I don't know how you know that teamwork is occurring, because you're not listening in real time the way an English speaker, a proficient English speaker might, to know that handoffs are occurring well. I don't know how you feel fully respected or how you get all of the information that you need unless appropriate language support is provided. So all of those key drivers of loyalty hinge on language needs being met. And then the second way that organizations optimize likelihood to recommend is, the highly reliable behaviors, the key drivers are first, and then how do we eliminate friction points? And typically they're looking at things like access, scheduling, wait time. But to me, the biggest friction point was if I can't understand and communicate and you're not making an effort to make that easier for me, that would be a gigantic friction point that would also erode loyalty. And then finally, we talked a little bit earlier about the notion of belonging. It's critical for staff. It's critical for patients to feel like they have a relationship, especially when we're talking about a high intensity health experience. That feeling of belonging is supported by seeing that person as the individual with the needs they have and meeting those needs. If you're like, yeah, sorry that we can't meet your language needs, that's a really big long arm, like we're not sending the message that you belong here. So I think all of that, it's how people think about their strategy anyway, bringing language into the effort as opposed to language access or language services being separate and a different, distinct avenue to those loyalty outcomes.
That's fantastic. I know anecdotally, hospitals that have robust programs have seen patients move far outside of their service area and continue to come to their hospital for care. Not just because there are great doctors, but because the language access is available. It's readily available on the phone, it's available online, it's available when they come in. And so patients will drive hours for that language access. So anecdotally, we know this is true, but it's nice to tie it into data that's being collected by Press Ganey and other organizations. Tina, Bruce, what do you think about the correlation between building language access infrastructure and market share in patient experience?
I'll jump in here. I mean, just from on the point that you just made, I think because it's not just about having a great language access program that affects just the care encounter, but it's that entire experience, as you mentioned, from the way you schedule an appointment, how you interact, all your different touch points and entry points into the healthcare system. So when you have a good program, and patients feel that you can communicate with them, and again, they get that information that they understand at all of those different points, not just if they go to see a long-standing provider that they have an established relationship with that knows that they need an interpreter. But if that program can affect all of their interactions, then there will be a lot more relationship building within that system. And then, again, people talk to their family members and friends and say, I had this great experience at this organization and I felt that my care was beneficial, and I understood what I was supposed to do, and I was involved in those decisions. And so I think it makes that the care encounter, so much more effective, but then the entire experience more effective. And I think that that's something that organizations, when they think about how they want to design these systems, I think one of the questions that came up a little bit earlier was about one of the things that you kind of need to do first is really understand who your patient population is, and look at the data that that Deidre mentioned and that Bruce mentioned, as well as hopefully if you're in one of our accredited organizations, you're collecting race, ethnicity, and preferred language data, because we have had those requirements in there for years, and that you're able to take a look at that, see who the patients are. I think with our new standards that we were just releasing that will be implemented in January, we have a new requirement about stratifying outcomes, and we talked a little bit about that earlier as well. But being able to look at your outcomes data, your care experience data, and look and stratify that by different demographic categories to identify, again, what disparities might be occurring in your patient population as a first step, and then figuring out how you would put an action plan together to address those different disparities. And I think, again, depending on which populations you check or which demographic categories you're using in that analysis, a language access program would be part of those discussions
I
and
think
maybe expanded in this process.
And I think in addition, there have been demonstrable cases in New York City, for example, in the Washington, D.C. area, of systems that have increased language access, cultural awareness training, and even, which is a big part of my scholarship, implicit bias training and microaggression training. They've actually seen an increase in LEP populations that use their facilities and more staff retention, more staff loyalty, better workplaces. So all of it is tied into this big knot. And it's all one, everything factors in. So when you look at it that way and realize that there are clear objective examples that HHS, I know, collected a couple of years ago, like, as I said, in New York City, that shows clearly that the hospital is increasing revenue as a result of their language access program.
That's fantastic. I know this is something that language access program administrators struggle with, is how to prove that connection between building a program and the return on investment, the increase in revenue.
Yeah, I'm sorry, Vanessa. One
Go
thing
for
you
it.
reminded me is I think I saw a comment about this. My friends at the Department of Justice said in an investigation in North Carolina several years ago, the cost of language access is the cost of doing business, period. Just like all buying scalpels and soap and all bandages and the latest scanning equipment, this is the cost of doing business, period. Deal with it. You pay your electric bill, you're going to pay your language access bill too.
No, I love it. I love it. That's a great analogy. And we do say language access is not a faucet that you can turn on and off. It has to be available at all points of care, but also at all other points of contact with the organization. And patients shouldn't have to drive or take buses 2 or 3 hours away to get language access. It should be something that is built in every healthcare organization, in every community. So our final question is a two-part question, and it's asking you to look to the future. This is an uncertain time for many, but all times are uncertain times. This is not the first time interpreters have looked forward and said, will we be replaced by offshoring? Will we be replaced by AI? Are all hospitals going to shut down their programs? So, periodically there is uncertainty about the future based on things that we see happening around us. So in your professional opinions, what is the future of language access in healthcare? And what can all of us do to effect positive change in our organizations and fight against any backslide to risky practices? It's a big one. I'm curious to hear what you have.
I'll take a chance at a tiny piece of that, which hopefully is an optimistic one. And that is, I think the combination of equity work and consumerism will help the organizations that are saying, oh, let's see if I get sued, that sort of thing. They won't be able to survive if they're not creating equitable outcomes and meeting the needs of their consumers. And so I do think that doesn't make it easy, but I think it creates continued pressure that will only increase, that consumers will have more say and more impact on the way organizations provide care.
And following up on what Deirdre said, look at the 2020 census data. We are continuing to change and evolve as a nation. More languages, more diversity, that's not changing. These laws that we're talking about, they're not going anywhere. You can book it that that's not going to happen. And I usually don't talk unequivocally, but I'm going to talk unequivocally with this. So the census really is a window into who we are and where we're going. It's been true for the last 20 years. It's going to continue to be true. And I also have to, again, I want to reiterate the importance of education, advocacy, and training. And I want to draw a quick analogy between what happened a couple of years ago concerning disability discrimination and the provision of COVID-19 care and liability. There were significant issues in multiple states of states and healthcare systems discriminating against people based on disability in providing COVID-19 care. Several disability organizations advocated strongly and quite effectively in talking to HHS and working with the healthcare systems. So that HHS actually did in 2020 some vigorous enforcement and got these healthcare systems to change their quality of care standards to eliminate disability discrimination. Let's see that with people who are LEP. Let's see the same type of efficiency, effective advocacy to do something as tremendous as what happened 2 years ago regarding disability discrimination and COVID care.
So Bruce, how do we get there? This is an unplanned follow-up question, but I see there are many interpreters making comments. There are language service providers in the chat. There are some hospital administrators. What can we, each of us, do in our different roles to make sure that advocacy goes somewhere? How can we be strategic about this together?
So Vanessa, with 8 minutes remaining, that's like a right-on question. Well, but that's to the point of what we've all been talking about. Knowledge and awareness drive policy. And as I said, if you look at what happened 2 years ago, these disability rights organizations were powerful advocates across multiple states, coast to coast. And they all changed their systems. They all changed their quality of care standards and guidelines. So there's no question that effective advocacy is possible, but I have to emphasize that does not mean spending time on Capitol Hill. Congress is not doing anything. Unfortunately, that's our reality right now. But the federal agencies are working on these issues every day. And it is the rare program, interpreter organization or otherwise that spends a lot of time talking to my friend, the Assistant Attorney General for Civil Rights, because they're the people who actually enforce these laws. They're the people who say, hey, you know what? We're going to have to take $100 million away from you because of these Title VI complaints. So advocacy directed more at the agencies and less at Congress, I think, is one place to start, coupled with better training, education, and awareness.
Well, that's incredibly encouraging. What I hear you saying is that there is a future for healthcare interpreting and for healthcare interpreters in the United States if we advocate strategically in the right places.
Well, I couldn't have said it better, Vanessa. Thank you.
That's incredibly encouraging. Tina, what do you think about the second part of the question? How can each of us fight against a backslide to risky communication practices?
Sure. Well, I think part of these new standards that we have going forward, I think I was kind of monitoring some of the questions coming through and some of the comments in the chat as well, since I know some of those are for me. But I think one of the things that folks have been saying about, we've never been asked about this on survey, or it's inconsistent. I have a large system, and somebody asked me about my language service program in hospital A, but then they didn't ask me in hospitals B through D. That kind of a thing. I think with the launch of these new standards, I think there's going to be definitely an increased awareness. Obviously, whenever we release new standards, there's some launch activities. We write articles. We've posted a number of things on our website, and organizations really start to look at that, because there's starting July 1, there's that 6-month window of sort of preparation time before our surveyors come out on site in January of 2023 to start to evaluate compliance with these new requirements. And this shift that we've had into looking at disparities and health equity issues as a quality and safety problem, I think elevates this conversation in a way that really hasn't been in the past, and brings it to the same level as some of those larger initiatives that we've talked about. And so I think many of the folks on this call working in different areas here may be pulled into some of those meetings as your organizations, start to look at these standards and think, what are we doing about disparities? How do we identify patients? How do we stratify our measures to identify disparities? What are we doing? We put together an action plan as one of the new requirements to address one of the disparities that your organization identifies. If that has to do with, communicating with patients and different patients, different preferred languages, then you'll largely be part of those discussions to see what is our language access plan, what are the services that we provide, and how can we adapt those or expand them to better address the needs of these different patients that we have and reduce those disparities. And so we have requirements in that new set about, again, action plans, looking at, taking action when you don't meet the goals in that plan, reporting out on that plan across your organization to individuals that may be involved in the work, but also keeping the organization as a whole, aware of the work that you're doing. And so I think sometimes, there were some questions that came through about, when is somebody going to ask me about this on survey? I can tell you, January 2023, our surveyors are going to start to go out in hospitals, our smaller critical access hospital programs, the healthcare services side of our behavioral healthcare programs, as well as the ambulatory organizations that we have that are focused more on primary care, not the episodic or surgical services, but some of a subset of our ambulatory organizations. And our surveyors will get education on these new requirements, which again will not just be about these requirements, but again will probably be a more general education to kind of boost awareness and make our surveyors more comfortable surveying for these issues. And so I think it will address a lot of some of the concerns about maybe you haven't seen the Joint Commission ask about these questions in the past, or it's been in different surveys, or depending on which area of the country you're in, or what the surveyors key issues are that they're looking at that time, or what tracer patients they pull. I think with the launch of these new requirements, it will just add a whole new level of interest and awareness around these issues, and sort of rising tide lift all boats kind of a thing, where we'll do the surveyor education. I think there was a question in there about updating the roadmap. We'll have education and resources available on our website too, and sometime in the next couple of months. So we have I just had a meeting early starting at 8 in the morning this morning about some of these issues. I've got some meetings stacked in the afternoon. So we are definitely doing a lot on the Joint Commission side to launch these new requirements and provide resources to organizations, and make sure that our surveyors and all of our support staff internally are ready for the questions and the support that we can provide going forward. So I'm hopeful that we'll continue to get questions about what organizations can do and how we can all draw attention to the great work that many of you are already doing.
That's very exciting. I know when the Joint Commission enters the room, hospital execs stand up straighter, sit up straighter. Everyone is eager to know what it is that surveyors will be asking. And I know that language access program coordinators in hospitals and health centers are always very excited when these questions get asked, because it leads to improvement in their organizations. Things that they've been advocating for a long time, the Joint Commission can help make happen. So thank you all. Thank you for your participation in this panel, Dr. Cordero, Dr. Mylod, Bruce. Thank you, Amy, ASL interpreter. I'm seeing comments in the chat that say you're doing a fantastic job, and we appreciate your support. Thank you very much. And thank you all for joining this wonderful webinar. There will be more throughout this year of on-the-road activity. The National Council on Interpreting in Healthcare will bring you many more learning events, some virtual, some in person. We look forward to your increased participation. Check back on our website, ncihc.org, for more resources to help you build language access infrastructure in healthcare. Thank you all, and have a wonderful day.
Thank you. You too. Bye-bye.